is a female in her late 20s who got a pelvic MR. So what her uterus looks like. And she's not recently postpartum.
Wow.
Yeah.
I've never seen a uterus like that.
I've never seen that before either. Any thoughts?
I see some discrete lesions like fibroids. The junctional zone, though, looks thin.
I don't see, yeah, it's a thin junctional zone. I don't see much of a junctional zone.
Yeah. Is it just like weird, like diffuse leiomyomatosis?
Yeah, there's an entity called diffuse uterine leiomyomatosis, when the entire uterine myometrium is replaced by fibroid tissue. And I think this is what this is. Seems like there's only a few case reports of this online. This is what it looks like on what's up radiographics. And it looks very similar age group as well. And this could be, it's typically treated with a hysterectomy, but there's some case reports of people using uterine artery embolization to try and treat this initially prior to hysterectomy. And she had a history of infertility, so I'm not sure exactly what literature says about whether or not these patients can get pregnant. But she was mainly having bulk symptoms and vaginal bleeding.
Well, it's amazing how smooth the endometrial lining is there. Go ahead.
That's exactly what I was going to say, Aarti. Why is there no mass effect when we see individual submucosal fibroids, there's so much mass effect, and that's what causes infertility or increases risk, right? In this one, yeah, it's so smooth.
Yeah, very smooth. Doesn't look displaced or anything. Yeah, you're right.
Maybe because it's not a mass, it's like infiltrative.
Yeah, not sure.
But anyway, I made up that term when I said diffuse leiomyomatosis.
Yeah, it's an actual entity. It has its own like radiopeda page and everything. Yeah. So it's the first time I see that.
Very cool.
And that's all.
So, this finding is not subtle, but I'll explain to you the interesting angle of this case. This is an older gentleman. This was an MR that we interpreted outside place. As you can see, there is the left kidney is abnormal. And as I scroll through coronal T2 weighted, you see this thing going into the renal vein up to the IVC. On the axial T2s as well, you see the entire kidney seems to be replaced or distorted by this lesion, and there is a thrombus extending into the left renal vein as well as IVC. And then I'm going to move my screen down just a little bit. On the post contrast,
actually like a beautiful example of like the loss of the flow void with the evil gray tumor growing
exactly on the axial T2. Yes, perfectly said. And then just the post contrast imaging finding of the same. Now, the interesting angle here is this an RCC? Because you know that this is a tumor. There is tumor within the renal cortex as well as within the collecting system. And in fact, this structure, this soft tissue here, which extends into the renal pelvis is, there was some low-grade enhancement within it as well. I apologize for the background noise. So the question is this a renal cell carcinoma extending into the collecting system? Because as we all know, and this is clearly a tumor thrombus, as we all know, renal cell carcinomas more commonly extend via tumor thrombus into the renal vein and IVC. So is this RCC going into the collecting system, or is this a primary urothelial malignancy? But urothelial malignancies rarely have tumor thrombi extending into the renal vein and into the IVC. So any thoughts, discussion? The coronal post-contrast is a little motion blurred, but you can kind of get the sense that there is a little bit of focal ciliectasis because there is obstruction to the calyx. There is some soft tissue within extending into the renal pelvis, and there is this mass over here as well. So any thoughts?
I think this is it's exactly what you said. It could be either. It's a great case for a biopsy because they will be treated differently. One with just nephrectomy and one with the urothelial with nephroureterectomy, all the way down to the bladder. But I will say of all I've followed up multiple cases like this now, and most of them end up being some kind of sarcomatoid RCC. But I had one case of a urothelial that invaded the vein.
Excellent. Yeah. So to be honest, here's the climax. I don't know what this is. This will come out or this will be treated accordingly. Sorry, I just thought it was interesting and I'll give you the follow-up. But I agree. When I looked at literature, they would clear cell subtype of renal cell carcinoma can do this. Very rarely go into the urothelium once it's so big, and sarcomatoid type as well can do this. I found literally just one case report where urothelial had a tumor thrombus going into the renal vein. But as you rightly said, Aarti, it's more common for renal cell carcinoma to do this once it's, and typically they tend to be high grade, high Furman grade, or very aggressive subtypes of renal cell carcinoma. So, we all look forward to the follow-up on some subsequent conferences. All right, I'll show you my next case. This image is a little blurred, right? But it will do.
No, it's okay.
Okay, so young lady presents with sudden onset breathlessness. She has right-sided pneumothorax. Her left lung looks okay. There's nothing going on here. And this is a few years ago. Feels fine after almost 5 or 6 years. Comes into the ED with sharp right upper quadrant pain, and so gets a CT. Doesn't have pneumothorax at this point. That was just one episode in time, healed, done. And then this CT shows a small nodule on the surface of the liver or at the periphery of the liver, and a small subcapsular fluid collection. There is nothing else going on here. So they decide to watch her, not sure exactly where this fluid is from. And then she, this episode subsides, does well, goes away. Then again, after 1 year almost, again presents with right-sided pain. And this time she gets an MR. Here is the axial T2 fat sac. So that nodule is still present. And I'm going to quickly run through multiple sequences. So the nodule which looked bright on T2 is bright on pre-contrast T1 as well.
Endometriosis.
No other findings. Exactly right. And this is the most recent. Yeah, indeed. But the reason I'm showing you this case is because this is one of the largest examples of endometriosis adjacent to the liver I've seen. And actually, let me show you the T2 on this. This is a case shared by one of my colleagues, so I can't take credit for this, but he presented this so nicely. And this actually came out, and this was a perihepatic endometrioma. So let me show you the axial T2s here. You can almost see the T2 shading within that lesion. I knew endometriomas were common in the ovary, and typically we see small implants along the hepatic surface, but this was what was called an endometrioma at pathology. So that was the interesting angle, I thought, in this particular case. Okay.
So Kedar got it. Also, catamenial pneumothorax, he said, and Rupert said, nice teaching case. I did have when you briefly scrolled to the pelvis in the prior CT, I saw like a lesion in the right ovary.
We can always go back.
I'm just curious if they also had, pelvic endometriosis.
Yeah, let's go back to the pelvis. Let's see. Let me see. I don't have dedicated pelvic images, so maybe it was seen partially as I scrolled through the coronals, perhaps. I just have all.
Yeah, it was
abdominal
actually on the
imaging,
CT
so-
that I saw the ovarian
okay.
lesion, but it's okay. It's
Yeah,
not
that's
essential,
okay.
but
Yeah.
um,
But endometriomas can occur in isolation here.
Yeah.
Right there. This is what you saw. Nice observation. I don't know whether this is an endometrioma or just a simple cyst. I don't have any other pelvic imaging on them. But in general, these things can occur in isolation as well. All right, I'm going to stop sharing.
that was a beautiful case. And
Great case.
I always tell my trainees that the reason it goes to the right lung base and also like between the liver and the diaphragm is because of the peritoneal cycle. It goes in a certain direction and it pushes stuff up into the right upper quadrant and like kind of between the liver and the diaphragm. And then I didn't know this before I was like looking at papers about it, but that there's fenestrations in your diaphragm. So the endometriosis deposits actually just travel through the fenestrations to the right lung base. I thought they hematogenously went to the lungs, but that's not how they get there.
You know, there are multiple theories why this happens, why endometriosis happens in general. No one has honed in on exactly one theory. But like you said, to me, the most plausible theory seems direct implantation. You know, so many examples, scar endometriosis or location in the pelvis where they are implanted. And like you rightly pointed out, the peritoneal cycle and fenestrations. We'll see, more research is needed.
The peritoneal cycle also is why they sometimes get deposited in the region of the appendix and cecum and in the cul-de-sac. And then it's why they don't get deposited in the left upper quadrant because the splenorenal ligament protects them from traveling up to the left diaphragm.
Yes, and the same reason is why canal of Nuck is to some extent the round ligament and canal of Nuck is spared on the left because of the sigmoid colon as opposed to the right side where it is seen more frequently.
Oh, I didn't know that. Wait, tell me that again.
So when you have canal of Nuck endometriosis, it is said that the right is more commonly involved than the left side because the sigmoid colon offers some protective effect to the left canal of Nuck and left round ligament as opposed to the right side. That's one of the theories.
Got it.
Yeah.
Cool. Okay.
All right, those are my two. Thank you.
Is it showing how many series do you see?
Just the axial.
Okay, perfect. So this is a young male who presented with severe left upper quadrant pain. And this is the finding right here.
Torsed splenule, Omar.
Yeah, infarcted splenule. I've never seen that before. It's a quick case. That's what it looks like. And they just treat this conservatively.
Cute.
Yeah.
Anu says, spot on, Rupa. Okay. Okay. So this was a patient who has colon cancer. And this is their liver. It's not the best phase, but you can see the findings. So Omar, are you going to describe every lesion? We know the goal here is to resect every lesion, leave them with, you know, the liver is kind of like a regional site of disease. We're trying to do a.
Of course.
You're going to describe every lesion?
Not in this case. No, there's way too many lesions, and the one in the inferior, I guess it's segment 4B, seems really, really big.
Yes. So with colon cancer, normally we try to describe all the lesions, but when there are multiple and they're bilobar, and we don't think that there's a future liver remnant that will be free of tumor, that's probably an unresectable case, for example, in this case. Other things that can make things unresectable are if it involves all three hepatic veins or the IVC. So this one is getting very close to the hepatic venous confluence here. Or if it involves both portal veins. This guy involving mostly the right portal vein here. But anyway, we have bilobar disease. This is unresectable. So in this case, our surgeons have started doing hepatic arterial infusion pumps. It was just FDA approved last year. And we're doing this for cases of patients who have unresectable colon cancer, but they can implant, they can put a hepatic arterial infusion pump into the GDA and deliver chemotherapy that's hundreds of times more concentrated than systemic chemotherapy, and it'll go just to the liver, so it has a lot less systemic side effects. So in this case, what they did was they went to the OR and they implanted the hepatic arterial infusion pump into the GDA and then into the abdominal wall of the patient. I'll show you the pump in a minute. And then they actually have to then clamp off all of the other branches of the GDA so that the chemotherapy doesn't flow in the other direction towards the pancreas or towards the bowel. So they did that, and then pull up. Okay, that's not. Okay, so they're still undergoing chemotherapy at this point. And actually, because of the chemotherapy, the mets shrunk and they actually started calcifying, which was kind of cool. We sometimes see this with mucinous metastases. In this case, it was actually just it happened with treatment. And then now you can see the pump. So here is the tubing of the pump. The pump is located in the abdominal wall. And the tubing goes up into, it terminates in the GDA here. And then does anyone know what this is? It's a nuclear medicine study that they did in this case after placing the pump. Is anyone still there? Hello, can you guys hear me?
Got it. So what
Yeah, can hear you.
Okay.
Yeah, definitely. We are all still here. No, it almost seems like the normal liver outside of the mets is taking up this. I don't know what the scan is.
So yeah, so this is really cool. So this is an MAA scan, and it basically just shows you where perfusion is happening. So they injected the MAA into the hepatic arterial pump, and it's going into the liver. So some of the liver is taking it up, and the mets are not necessarily taking it up. But the really interesting thing is that I told you this lands in the GDA. They've already cut off all the other branches of the GDA. And we saw this activity right here in the pancreaticoduodenal groove. So they were very concerned, like, what is this? And we talked to our nuclear medicine colleagues, and basically they said, this looks linear. So there is some kind of perfusion happening to this area here. And the main thing is that basically there was a tiny little branch, like an aberrant pancreaticoduodenal branch that they did not see in the operating room that was still active, and that the MAA was able to go down into. And so then IR got involved. Let me try to pull up the IR images. And they went into the hepatic artery and then down here, and they basically found this tiny little superior pancreaticoduodenal branch, and then coiled it. And then the other cool part is that they then repeated the MAA exam, and you can see that it's still being taken up by the liver, but nothing is being taken up in the pancreaticoduodenal groove. So I just thought this was interesting. I didn't know much about hepatic arterial infusion pumps. Are you guys seeing any of these kind of cases, or?
Not seen, Aarti, but I wonder, how does such a small caliber catheter stay in an artery like that without dislodging, right?
Stay in the artery? Is that what you said?
Mm-hmm.
Yeah, I don't know. Advanced surgical techniques. I mean, they're doing them now more and more at our hospital with unresectable colon cancer, as well as intrahepatic cholangio. They must just sew it into the artery. But they were very, very worried when they saw that little dot there. And I was kind of like, okay, so now you see the coiling down here. But like, if you infuse that very high dose chemotherapy and it goes down towards the pancreatic head, that was really what they did not want. Kedar says, very cool case. We haven't seen this at UAMS. So yeah, I hadn't seen a case of this. I thought it was really interesting. And we were debating, like, what does that little thing mean? And Angio showed us that there was still a little branch there. Anu says, super cool. Okay, I'm gonna stop sharing while I pull up my next case. And just scroll through. The finding is in the pelvis. This is the finding. You can see that there's a lot of thickening of the bladder wall, but that the mucosa appears intact. So it seems to be a submucosal process. It's quite thick, but not like a rounded mass. Here it is. This whole process here in the bladder wall. So any thoughts about a submucosal, diffuse, kind of infiltrative bladder mass?
Diffuse leiomyomatosis. I'm just kidding.
Yes, that would have been a cool companion to your uterus. That's it. I think that's a great idea. Submucosal leiomyoma is a good thought. That's not what this was. What else lives in the submucosa? So we're thinking smooth muscle. What's your other differential for like submucosal masses? We can think about nerves that are there. So paragangliomas, like that can lead to micturition syncope. And Kedar got it. It's neurofibromatosis. So this was a plexiform neurofibroma, biopsy proven, of the bladder wall. So just something to think about whenever you see like a kind of smooth, diffuse, large infiltrative process. I bet you on MRI, we don't have an MRI in this case, but it probably would have been like T2 bright, kind of like those other plexiform neurofibromas we've been showing recently, just kind of like blobby and growing in this kind of space. Omar says, cool case. Okay. So this patient has breast cancer and they had this metastatic lesion in their liver. It had been biopsied, and actually this is the biopsy track, which they biopsied it, and then on their way out, they ablated the track. So there was a little bit of kind of a linear, dead tissue at the along the biopsy track. And then they decided to treat this with proton therapy, which we have a proton center here in Atlanta at Emory. And proton, so normally radiation is dealing with photons, and they use hundreds of beams to kind of radiate the lesion. When you do proton, you do not have to do hundreds of beams. It comes from one direction, and it leads to a much, much higher dose at the location of the tumor. So in any case, this was the lesion after the proton therapy, radiation therapy to the lesion. And you can see that it's kind of also going along this track here. So what would you call this? Would you call this that the lesion got bigger?
Can we get a flare response with proton therapy where?
Yeah. So exactly. So that this kind of the point of my case here is like, do not overcall, especially after any kind of radiation therapy. You can get pseudo-progression, and proton therapy induces a lot of necrosis. So you can the lesion actually got quite a bit bigger, but it's because this whole area, the lesion was here, but they radiate a centimeter around the lesion. So that whole area basically underwent necrosis. And then you can see that the rest of this is in like a band-like fashion. And that's because in proton therapy, they come from just one direction. And so they can kind of necrose the tissue on the way. It gets like hotter and hotter as they get to the target lesion. So don't overcall this. This was actually called like progression because the lesion was bigger. But if we think about it, we have to give it the benefit of doubt. They blasted it with radiation. We've got some pseudo-progression here. It's in this linear fashion of the proton beam. So we followed it. And this was the lesion a couple of months later. I don't know if you can remember, but it's actually getting smaller. And then this was the lesion a few months after, and it's getting even smaller. So that's another thing that we should think about also with Y90. Radiation doesn't, work exactly like ablation. Like it takes a while for all the tumor necrosis to happen and for the lesion to involute. So remember that you can have pseudo-progression, and also that as long as it's getting smaller over time, it's likely completely treated tumor. Even if there's still enhancement within it, it's cells dying and necrosing and things like that. Okay, that was.
So the reason why we were doing this exam was for this lesion, which was like growing. This is a patient who has known neurofibromatosis. And so this was like a big presacral lesion, and it's pretty heterogeneous, enhancing very heterogeneously, a lot of edema. So this was, we said that this is most compatible with the kind of a malignant peripheral nerve sheath tumor. But also notice this kind of a heterogeneous thickening of the urinary bladder. You can see it better on this sagittal image. So given that the patient had neurofibromatosis and also has this lesion, we thought that we'll kind of put a differential of this being a plexiform neurofibroma of the urinary bladder. We don't have a proof of that as yet, but that's what we think it is. It's very rare.
It's so beautiful. It looks just like my case.
Yes. And few other things about neurofibromatosis, just like it's kind of a mesodermal dysplasia. You can see how dysplastic the sacrum is, right? You see that it's kind of dysmorphic. Also, sometimes you can get like other things, like this patient also had a aneurysm, saccular aneurysm over here. So there are other things which can happen, including skeletal manifestations with neurofibromatosis.
Very cool. I know you guys do a lot of MSK, and I'm wondering if you can tell us when do you bring up malignant peripheral nerve sheath tumor versus just, I don't know, a large neurofibroma?
Yeah, so many things. Basically, it's predominantly the appearance, size, heterogeneous signal, and if you do like diffusion weighted imaging, if you see restricted diffusion. So those are some of the criteria we use. In fact, there's a paper which said that if you have ADC, and if the ADC is less than 1, then almost 100% time that is a malignant peripheral nerve sheath tumor.
Very cool. Thank you.
Mm-hmm.
And you can see how it looks different than a plexiform one, where like those are more like blobby and kind of growing around structures. This one is like a solid mass.
Yes, yes.